You know, and when you're renting, you got other people that are responsible for upkeep. Not when you buy something.
They mow for it, or depending on where you're at. They mow for you.
Oh, yeah, with you. Nobody mows for us. Can't even get him to mow for us. He's like, I can't wait till the kids get old enough. Just can't wait. Which they're old enough. My oldest one is 10, and he's learned how to do ride the lawnmower. He'll just ride all over. He pulls the blades up and just rides everywhere. He's like, put the blades down. He said, no, I'm scared. All right, we're going to talk a little bit about arthritis. The chapter 21, the rheumatoid arthritis assignment was due on Monday. Remember in the beginning, I told you that I set due dates for these now. So unless I have a good excuse, I won't accept them now. They're not, if they're late. Okay. So we're mainly going to talk about some interventions that has to do with arthritis. Tell me what you all learned about rheumatoid arthritis as you were doing that assignment.
Pretty much hard for them to do anything.
Hard for them to do anything.
With their hands, especially.
At what times? All the time or
At night.
nighttime? Okay. What are some of the characteristics or some of the symptoms that you see with rheumatoid arthritis?
Isn't there swelling? Swollen.
Right.
They can't really move on around, right?
Grip.
Yeah.
Right. What are the most affected joints in RA?
Is it the metatarsal?
Yeah, the small joints. Is OA and RA the same thing? Somebody tell me the difference between osteoarthritis and rheumatoid arthritis.
Osteos in bone. Osteos in the bone.
Not necessarily.
Okay.
It's part of the bone, yes. The biggest difference in OA and RA is that RA is an autoimmune disorder. OA is what you think of as arthritis. Okay, OA is a wear and tear disease. Normally occurs in the joint, in the weight-bearing joints. Okay, the knee, the hip, the ankle, but can be in any joint in the body.
So the autoimmune one is just your body attacking.
Yes, it's the body attacking itself. Your immune system doesn't recognize your body, and it attacks itself and turns into rheumatoid arthritis. Rheumatoid arthritis has remissions where the person, if they're in an active bout of RA, that's when they're going to start getting the fever, the achiness, the fatigue, loss of appetite. They may have weight loss, stiffness. And that's when you're going to start seeing most of the deformities. With OA, there is no remission. The biggest, what you do for RA is rest. When a person is in a exacerbation period of RA, rest is the best thing to do. They also will give medications, things like that, but rest of the entire body, not just that particular joint. You also want to give them interventions that will decrease the deformity. So there's splinting that you can do for RA. We have what we call, and I'll show you the pictures in a minute, finger splints or ring splints. And that just keeps the DIP joint here in the finger from going over, from just moving over. Or the ulnar drift is what they call it, where it looks like the whole ulnar side of the hand is drifting over, and that's just the joints moving. So there's a splint that you can give them that will push that joint, help keep it from doing that. Another thing for RA is you want joint protection techniques. So anytime that you got to open a door, which way do you turn the doorknobs? Toward the pinky, right? Which way do you turn to open up a jar? Toward the pinky. Close a jar, toward the pinky. So with RA, you're just going to teach them to use the other hand, right? So to open a door, instead of opening it with their right, turning toward the pinky, they're going to use the left hand, turn towards the thumb, right? Same thing with opening a jar. They're going to open the jar, turning towards the thumb. And you can get those jar grippers, things like that, to put on top of the jar, make it easier to open. They're going to turn it towards the thumb. And then to close it, they use the other hand and turn towards the thumb. So any joint protection technique that keeps them from turning toward the pinky or the ulnar side is good for someone with RA. Would you use heat on a person's joints when they have an exacerbation of RA? No. How come?
It'll make it more inflamed.
Right. The joints are already red and swollen and inflamed. They're already hot. You don't want to heat them up more. And if I'm not looking straight at y'all, or you think that I'm giving you the eagle eyes because my glasses broke and I can't see any of you. So I'm trying to squint to focus. I mean, I can tell like who's a girl and who's a boy. And I can tell by the color of your hair where you usually sit, but I can't make out any facial feature. So if you're making faces at me right now, I probably won't know. So I'm not giving you the evil eye, I just can't see you. So good. So that is some characteristics and some interventions with RA. Now you can use like cool towels, things like that on the joints to help cool them down. And also you want to concentrate on energy conservation techniques, work simplification, have them put their frequently used items closer together to keep them, like if say you've got an upstairs bathroom and a downstairs bathroom, you spend the majority of your time downstairs. Then the stuff upstairs that you use all the time should probably be moved downstairs to keep them from having to go up and down the steps. Same with the bedroom. If their bedroom is upstairs, you may want to have them move their bedroom down. Especially if they spend the majority of their time downstairs. And also you want to consider their social life. Usually by the time that they get up in the mornings and do their cleaning and do everything that they've got to do, they're so wore out that they don't have time to go out and do anything socially. Just, encourage a social life. So if they have to skip cleaning, or if they have to do half of it and then take a nap and then get up and, then go out socially, then that's what they should do. Because the social participation and the leisure activities are just as important as everything else. Okay. So OA, what OA is a breakdown of cartilage, and it causes joint pain and stiffness. Now with RA, it's symmetrical, okay? What happens to one side of the body is going to happen to the other side of the body. With OA, that's not the case. You can have osteoarthritis in your right elbow and not in your left elbow. So it's any joint that can be affected. With OA. Now, the best treatment for OA is movement. And it hurts, it's painful, you know, but the best thing to do when a person complains that they have osteoarthritis, and they're gonna hate you, they're not gonna wanna do it, but it's to move. The best thing for them to do is to swim, okay? But you know, if they don't have access to a pool or something like that, then just any exercise, any movement is better than none. Because the longer they sit around, the stiffer their joints become, and the harder it is for them to move. Anti-inflammatories can help, but you have to watch how many you take of those, because that can also cause stomach bleeds, stomach ulcers. Pain management, you know, you can do different modalities that may help with E-stim. Hot packs especially, you can do hot packs with osteoarthritis. You can do E-stim with osteoarthritis. You can do ultrasound, things like that. But those are just Band-Aids. It's not, you can't cure an itis. Any type of itis cannot be cured. Okay. Orthotics, adapting the way that they do normal activities, education, things like that. Joint or energy conservation, work simplification, stuff like that can be done. But again, the best treatment for osteoarthritis is movement. Okay, so what is the best treatment for what should you recommend for rheumatoid arthritis? Rest. Okay. So, and you'll need to know the difference in the two. That'll be part of your exam as well. But, and one of the biggest ways to tell if it's osteo or rheumatoid is does it get stiffer and more painful as you use it, or is it mainly stiff and painful in the morning? Rheumatoid gets more stiff and painful as you use it. Osteo is more stiff in the morning. The more you move, better it gets. And I can't tell you how many people, especially elderly people, that tell me well, they call osteoarthritis rheumatism. My rheumatism acting up. And I can't tell you how many times I've said, well, you know, we need to do some exercise, and they cuss me up one side down the other. I just told you I had rheumatism. Okay, then you've got fibromyalgia, lupus, and gout. Those are all three signs of arthritis, or they are part of arthritis. Lupus, again, another autoimmune disorder. Pretty much treat that as you would rheumatoid, with what things you're going to recommend. Fibromyalgia, the best thing for that is swimming. And I'm a proponent for swimming. Everything swimming. Do swim. You got a cold, go swimming. Fibromyalgia is characterized by the fog. They have like a brain fog, and they will tell you that they feel like they're in a constant state of having the flu. Their body is just like, that's how they feel all the time. How many people in here have had the flu before?
Oh, yeah.
Yeah. So how your body aches, that's how they feel all the time with fibromyalgia. So you do need to know some of the common pharmacological pharmacological treatments of arthritis and some of the things that it causes. If they're on arthritis medications, and you know that that medication has side effects of dizziness, drowsiness, tinnitus is ear ringing. It has a side effect of dizziness and drowsiness. What are you going to be extra cautious of when providing treatment?
You're gonna definitely be near them at all times, so they don't fall.
Right, safety concerns. Anytime that you have a person whose side effects of medication is dizziness, you definitely want to be extra cautious with when they're walking. Anytime that they're going to the bathroom, standing up to change clothes, anything like that, because it could be a severe safety concern. If they're dizzy and they fall down and hit their head, then you've got more than arthritis to deal with, right? You got traumatic brain injury, you might have death, you might have a broken hip, you never know. That's the way that some of those side effects can affect OT intervention. What about elevated blood sugar? What if the arthritis causes elevated blood sugar? Do you know what the result of elevated blood sugar usually is? Confusion and drowsiness. Okay. Nausea and vomiting. How is nausea and vomiting going to affect OT intervention? Yeah, but see, you got to be close to them so they don't fall from the dizziness.
Maybe don't have them cook food that day.
Or stand behind them or beside them. Don't stand in front of them. Ear ringing. How many people's ever experienced long bouts of tinnitus? I have never experienced long bouts of it, but sometimes my ear will ring and it drives me up the wall. Some people's medications cause it to be a constant low ringing of their ear, in their ear. That's definitely going to affect OT intervention. That's going to affect a lot of stuff. So keep that in mind if they say that they suffer from tinnitus. Okay. Yeah. Very angry. There's some surgical treatments. So how do you think that arthritis can affect a client's psychosocial well-being?
I don't think it would be positive. For sure.
Why?
Because they're like,
You're not gonna wanna do it.
yeah, it's just gonna be like, well, why would I do stuff that's gonna make me hurt?
Right.
They might have role changes, like if they cook or clean for the most part, and then they can't do that.
Right. Role changes.
Just like their mood would be down from that and stuff, I would say.
Yeah. They're just and being in constant pain causes a person to have depression.
My dad has gout, and like when he gets gout attacks, like he's up all night,
Yeah.
like his ankles swell up and it looks like a softball on his ankle.
Yeah.
It's so bad.
Yeah. Most commonly, you get your ankle and your big toe gets gout, and it's just you can't bear to put. So, as an OT or a practitioner, what sort of interventions would you do for a person that has gout?
The only thing he does is really like rest for him.
But he still has stuff he's got to do for
Yeah.
himself.
Is there like
So, what interventions would you do?
a boot or a splint to put on it to help them relieve
You
that
want
pressure?
nothing touching it.
Nothing on it.
Nothing touching it. Not a sock, not ice, nothing touch. to touch it. And there's no cure for it, right? Because it's a form of arthritis, and arthritis can't be cured. So what types of everyday activities do people have to do that gout could possibly interfere with? Because walking is difficult. You know, everything that has to do with anything is difficult with gout. So would you give them adaptive equipment? What type of adaptive equipment could you provide? Breachers.
Maybe so they don't put so much pressure on that foot, maybe something higher elevated, like a commode or a higher elevated seat.
Yep.
Walker, maybe.
Walkers may help. They may, to keep from putting so much pressure on the foot. So keep that in mind. Just because it's not a ailment that we can treat, doesn't mean we still can't work with these clients to help make their lives a little bit easier while they're experiencing their exacerbations. Does everybody know what exacerbations means?
Things that get in the way, kind of like
When it's worse. Yeah. Like rheumatoid arthritis, when you're in an exacerbation period, that means that your joints are swollen, your joints are red, you're inactive RA. Someone who has an exacerbation of gout means that they are in active gout. They have active gout. When they don't have active gout, then it's not a problem. Do we ever tell our patients no pain, no gain? What can we teach them instead of no pain, no gain?
I think education will come really in handy. Be like, yeah, I know you don't want to do this, but if you do it, then you'll have more benefits or whatever.
I always see the saying, see the able, not the label.
Hmm.
See the able, not the label. I've seen that quite a bit.
Yeah. One thing I always tell my patients is to respect the pain. We can't tell them, if they say, I'm in a lot of pain right now when I'm doing this activity. You tell me that, and I say, well, you got to get over it. Keep going. Or if I don't believe you. If you say you're in a lot of pain, I say, I don't know if it really hurts as bad as you say it does. That's not going to be good. So I tell my clients to respect their pain. If they honestly feel like they cannot complete a certain task because their pain is too great, then they just need to not do it. And a lot of times, I will say most of the time, when I say something like that, they'll kind of push themselves a little further. There's a couple of patients that I've had that when I've said they're like, okay, I'm quitting, I'm done. No, and good and well, they wasn't hurting as bad as they said they were. They just didn't want to do anything. And also, after you complete a specific task, if the pain, to pay attention to how long the pain lasts afterwards. If it lasts 1 to 2 hours after the task is completed, then it was just too much. Don't do it again. I mean, just don't push yourself to that point again.
That's what one of the videos said too. Yeah.
Yeah.
Like less than the exercise as it goes on.
Right.
Yeah.
Yeah. And you tell your patients, that you do a specific exercise, pay attention to how long the pain lasts, report that back the next time they come in, and if it was more than 1 or 2 hours after they did the exercise, then you need to back off a little. Downgrade it, just grade it down just a little bit. And if they report that the pain wasn't bad, then you can keep it where it's at, or maybe even move it up a little. But you don't want to cause pain in your patients. That's not what we do. That's physical therapy. They cause pain. How many people's ever went to physical therapy?
Hated it.
You
what?
know what happened to
Hated
you.
it, hated it.
You know what happened to you.
Like, hated it, hated it. Even before they shocked my leg.
Yeah, I did. Yeah, I remember you telling about your leg went up to your
I'm
ear.
not exaggerating either, that was a legit thing, that, it was crazy.
Well, I work out at Body Works, and you see all those little people, they're just like doing this for like hours.
Yeah, it's just like going to the gym, so like, why would I pay to go to?
They're just like-
Just get a gym membership.
That in the area that's like hurting you, so mine was like my hamstring, so they had me on that bike for like 45 minutes.
Ooh, ooh.
That hurt me, like it hurt bad, and they were just like, don't worry, if you keep doing it, it'll hurt less. I was like, I don't see how it's working like that.
That's the same as no pain, no gain.
Yeah,
Exactly, they
exactly.
were like, just, you gotta finish it.
Did it help though in the end?
No, it lingered and lingered and lingered after my physical therapy was done. And then they had that little knob that did the massage thing, and they had the smooth end, and then you had that sharp end.
Oh, the breakup knot.
Oh my God, that hurt so bad.
Ooh.
I was sitting there just like, tensed up, every little bit of me just,
And then they stuck you on that E-stim and your leg hit your ear.
yep. I had like, I think 5 or 6 weeks of that,
Jeez.
5 days a week.
Oh my gosh.
Yeah, I quit going to places. This isn't doing anything.
I finished my thing, but I still was messed up for like a couple months after. I guess it just naturally healed.
Usually the hamstrings kind of. What were you playing, sports? Yeah. Did you not stretch them first?
We stretched everything. It was just,
And that was what happened. You just overstretched them.
I don't know. Like before, I didn't really stretch that good, but after that, like I love to stretch.
Oh, yeah.
Stretching so important.
But really, like that, just the way that they pushed me and stuff, and I didn't like physical therapy. Like I don't know.
My mom has been to physical therapy so many times for various reasons. And I ask her all the time if she just is like a masochist. She just wants to be in pain. Well, it's supposed to help decrease the pain. Well, does it? Well, no, then quit going. Go somewhere else. Now that's how I felt when I went to a chiropractor,
Yeah.
but he did help me. It hurt in the beginning, but it did help.
I love the chiropractor.
Yeah. But physical therapy, I have had physical therapy before, not prescribed, just because I needed it, and I've got several friends who are PTs. I'll not do that ever again in my life. Okay, so some interventions for arthritis. The first thing we're going to focus on is decreasing pain. Okay, decreasing pain is our main focus. And then improving function. If you can help decrease their pain, then you can help increase their function. It just kind of goes hand in hand. We can do that with environmental and lifestyle modifications, and to help decrease the risk of deformity or disability. So some environmental modifications would be what? What are some that can help with osteoarthritis?
Like you said, moving, like if they have 2 bathrooms, go to the one that's like easier to access for them or where they spend their time.
Right. I meant rheumatoid, not osteo. Yeah, and some lifestyle modifications. What are some lifestyle modifications?
Adaptive equipment.
Like you said, how they have to open certain things.
Right. And that's going to also help prevent their deformity, decrease their deformity. And the deformity is painful as well. You know, when you look at your hands, you want to see nice hands. You don't want to see your knuckles all moved over and swollen and all that. So that's another lifestyle modification that you're going to help them to do. Again, another one is to make sure they also participate in social and leisure skills. Okay, they can't, and because that is going to help decrease the prevalence of their depression. All right, so also another important thing to do with arthritis is to find out how many good days they have in relation to bad days out of 7 days a week, So if you've got 7 days out of the week, do you have the most is good days or bad days? And then also you want to observe how they perform their activities at normal times of the day that they would normally do it. And also, okay, so you can see how their performance may change at any given time during the day. Now, with someone that has rheumatoid arthritis, the best part of their day is probably going to be in the morning where they've rested all night. And the worst is going to be in the evening where they've done stuff and they're tired. So the opposite for OA. It's harder for me to get up out of bed in the morning sounding like a bowl of Rice Krispies, but after I've moved around and done things, then usually mid-afternoon to late evening is my best time of the day. So, it just, and, if an OT were observing me, they would observe me taking a shower, making breakfast or whatever first thing in the morning and also in the evening just to compare and make recommendations. I always take my showers at night, which really doesn't make any sense. It'd probably be better if I took it in the morning, but I don't like to get up that early. Why? Okay, so client education. First thing, respect the pain. Okay, if it lasts more than 1 to 2 hours, it's too much. Or the pain lasts more than 1 to 2 hours after the activity was over, it's too much. You want to use each joint to the maximal range of motion and strength during activities. So like when you vacuum the house, okay, how many people go all the way out and back in to vacuum, or do you just take short little? I do short little things too. Yeah, the best way to do it for someone who has arthritis is long strides. Okay, because you're using the joint to the range of motion that it should be used to. And not just with vacuuming, it's the same with like cleaning windows or just anything that you're doing. When I put my shirt on, I go, just kind of put it on and do it in a hurry. Anytime that they're doing any activity, they should always try to use their joints to the maximal range of motion everybody can. That can help decrease the pain. Also help decrease the prevalence of hospital deformities. Okay. Avoid stress positions. When you sit down or when you go to get up off of a chair or something like that, a lot of people will put their knuckles down like this and push up. Don't do that. And teach your clients, don't do that. Always have them stretch their fingers out and push that way. Okay? This increases deformities. This will help decrease the deformity. Okay? Avoid staying in one position. I know when I feel my worst is when I have to sit there at that computer for 8 hours a day doing something and I'm, not moving. That's the hardest. But it's hard for me to remember to get up and move around. But not to teach them not to stay in the same position for too long. If they're watching TV, reading a book, something like that, then at least every hour they need to get up and reposition and move around a little. Use a book stand to hold a book. So if a person's got arthritis in their fingers, I know it's really hard for me to hold my books if I'm reading a hardback or a paperback book. So I will use a book stand because my fingers tend to get cramped up if I keep them in one position too long. Same thing with when I read on my Kindle app. I've got a one of those pop socket, whatever they're called.
Yeah.
So I can, hold it however I need to hold it and not hold it in one position. Always use the strongest muscles available. So how many people will carry 18 bags of groceries in at one time to keep from having to make more than one trip? I do the same thing. My biggest problem is those skimpy little bags that they give you won't go up on my shoulder. So I've got like 9 bags in each hand, right? And I'm trying to distribute the canned foods in each hand. I got like a bag of canned foods here, a bag of canned foods here, which are so heavy, and I've got milk. And the best thing to do is to take have your clients take the non-disposable bags, the cloth bags that have the longer handle, so they can put it up on their shoulders or up on their bicep, because those are the stronger muscles. So you want to use the strongest muscles in the body and the larger joints. The smaller joints that you use tends to cause more pain. And if you have to make more than one trip, but my kids are old enough now to where they're the ones that unload my groceries. And they did the same thing too. They're like, I don't want to make more than one trip. Well, you are 40 years younger than I am. I said my back hurts. Well, you are 8. Your back doesn't hurt. Also carry heavy loads close to the body. Okay. You tend to, the further out that you carry a heavy load, the worse it's going to hurt, the more pain you're going to be in. Adaptive equipment that you can possibly give them. You want to be careful when you're giving adaptive equipment, because if you give too much, they're going to get overwhelmed and end up in a drawer. They're not going to use it. Okay. If it's something like a reacher that is going to keep them from using their full range of motion, do you want to give it to them?
No.
Now, if they can't bend at the knees and lift with their legs, and they have no choice but to just bend over and use their backs, then yes, a reacher would probably be more beneficial to keep them from causing too much pain on their lower back. But pay attention to what they do and how they do it before you determine that they automatically need this type of equipment. Okay. So also orthotics. Orthotics is another thing that we use for arthritis. Splint making, things like that. We can fabricate or provide some type of a splint or orthotic device. And the reason that we splint, the reason that we use orthotics is to help first decrease pain and to increase function and to prevent deformities. Okay. Resting hand splints are really common for people who have arthritis, especially if they have like carpal tunnel syndrome. And it's carpal tunnel syndrome. Okay, it's not just carpal tunnel. Everybody has carpal tunnel. Okay, the syndrome is what you don't want.
That's sad that I just found that out like not too long ago.
Yeah, well, and you're not the only one. People will come up to me and say, "Yeah, I've got carpal tunnel." I'm like, "Me too." Carpal tunnel syndrome. Okay, carpal tunnel runs right along through here. That impinges that nerve, and that's what causes the syndrome.
The more you know,
Uh,
the more you know.
the more you know, the more you grow. Oh. So resting hand splints. I have my clients wear those at night, especially if they have like arthritis or carpal tunnel syndrome, because what they do is they put their hand in this splint and it keeps it at a neutral position. A lot of times when they first wake up in the morning, their hands will be just really stiff. And that's normally because when they sleep sort of like this. And that impinges that carpal tunnel. It will also just cause a lot of problems with their arthritis in their hands. So resting hand splints are good. Edema management. You want to control swelling. And swelling in an extremity can cause an increase in the pain. So if you can control that swelling, it can help to decrease the pain. And it can also increase their functional use of their extremity. Thermal modalities can, and when I say thermal modalities, I don't just mean heat. Okay, a thermal modality is also considered ice. Icing can help decrease some edema. We're going to do some retrograde massage here in a minute. I'm going to show you how to do that when we go over comprehensive hand management. And like compression garments, things like that. If you look at page 548, that is on figure 2121. That's an edema glove. It's also called a compression garment. Some people call them Jobst garments. Jobst is just the brand name. It can be any other brand. Edema glove. You use those when, like after you do retrograde massage, you put that on a person's hand to help keep the swelling down. If you look at page 546 and 547, 547, figure 2120, that's a resting hand splint. That's the one I was talking about earlier. If you look at 546, figure 2118, these are anti-deformity splints. And that's 3 different splints. That's not one splint. That's 3 different splints. The person will have like a ring splint, and that helps with the boutonniere deformity. I'm trying to find the trying to find a copy of or find a picture of a ring splint. Oh, and when we do splitting, I'll show you all what a ulnar drift split looks like. They're pretty cool. Another thing I used to do to help people reduce the edema was after we did massage, I would have them wave at me, like every time I went by their room. And had this one little smart aleck lady, every time I go by her room, she'd go. But it did. I mean, it helped keep that edema out. And then, or I would have her act like she was clawing at something, and that would help move some of that edema out. Now, one of the precautions, contraindications to edema management is congestive heart failure. Okay. if you have a patient who has any type of edema, um, any type of edema, I don't care if it's severe or not, if they have congestive heart failure, there is nothing you can do about the edema. Okay? What'll happen is you'll get that edema pushed back into their body, but their heart can't pump hard enough to get that fluid flowing. So it will cause active heart failure, okay, and it'll kill them. The person will die. So that's one contraindication to edema management. All right, let's see. So ADLs, IDLs, think about how arthritis can affect these occupations, your self-care, IDLs, leisure, work, sleep, and sex. And what can OT offer the client to help them with these occupations? Okay, so that's what I want you to think about out of this chapter. I have got liquid or like something, I don't know if it's swimmer's ear or what it is, built up in my left ear. And I can hear it squishing. Like, when I move my head, it goes squish.
So hurts.
Oh, it is, it's awful. Can't see it, can't hear. Y'all can talk about me or do whatever, and I won't know nothing. All right, so we're gonna take a little break. And All right, so let's take, just, a couple minute break, go to the bathroom, do what you gotta do. Come back, and then we're gonna go over some hand management stuff, and we're gonna discuss retrograde massage, some more edema management things. And some interventions for the hands. Hand therapy is, we do hand therapy a lot. There's a lot of people who are actual hand therapists. You have to be an occupational therapist, and you gotta have like 1 million hours, observation hours, and pass a test and all that to be a certified hand therapist. They're very sought after. I don't know why anybody want to do it. I think it's the most boring thing in the whole entire world. But sitting there watching somebody do tendon glides forever. Oh, that's great. You're doing a good job. But just know that that's an option if you want to go on and be an OT and go on observation.
I love the knot. I don't know these guys. But not me.
I know what it means, but I can say.
I just want that. I'll sit there and look at you.
I don't have the brain power anymore to do it. Like this semester already, I could do graduate school.
I'm not the way for it now. Dude, like I said.
That's what I should have been. I just should have went to like get some to do with grass. I should have Yeah, do you know how much money them guys get that are like free? Like I can already run an excavator.
Dude, make your own company and I'll work for you.
I used to love running excavators.
On the golf channel, they were saying, is golf too easy for pros? And I wanted to send a picture to you so that I'd be like, look, hot take.
I get so mad when people say that. Roll back the ball. They're getting too far. I'm like, no matter, they're still pro. They're still strong.
Golf too easy for pros.
It literally does not matter. There's no wind. There's no natural thing that they can't. Because they're going to hit it straight no matter what. There ain't no wind or like water to slow stuff down for them. They're going to tear it up on that.
And go backwards, seeing about golf and
Seriously, like,
pros.
because that's like the hot topic. Everybody's wanting to
Yeah,
hit
they
it.
were talking about for a while.
Everybody wants to hit it a mile. And all them old heads are like, they're hitting too far. And I'm like, I'm not even gonna hit it that far. Yeah.
So we got a worksheet this Friday. It doesn't look too bad.
What, on Fieldworks?
Yeah, it's just one.
I have to make a comprehensive list. I gotta get some stuff done.
What do you doing done?
Or I did this
Knowledge
knowledge
assessment?
assessment. And I gotta make sure it turns in this time. I don't know why I didn't turn it.
I didn't either.
Yours didn't turn in either? Because mine didn't turn in. I turned it in at like 2:30.
What happened?
Maybe. Because I remember texting Lane about it, and I was like, here's what I got, all along the time. And like, it was right after I finished the movie,
Yeah.
and I just turned it in. And it's saying it wasn't submitted. And it shows on my last day that it
Where's
was
on,
last day,
Jerry's?
1/17/10/38.
You always will accept this to show that you did. Yeah.
So you like 100% did it too for me?
Yeah.
I didn't submit either. Because like,
Yeah.
I swear I turned mine up. I know everything. I don't know why I didn't do that. Like I'll straight up tell y'all if I'm procrastinated or just didn't do something.
Yeah. But you guys would say, well, we gotta do it. We have no, we can't get out of freaking
See,
grade.
look, last modified 1/17, verse 22, 10/38.
would tell her. That's all you can do. The worst you can say is no.
I'm not gonna lie, there's just some time where I send something in. So I changed the date and time on my computer.
I didn't know you could do that.
I'm not tech savvy.
I'm not either.
I changed the format somehow on my cat walked across my keyboard, and it's still like this, and it's on my nerves so bad, but I can't change it.
Oh,
I don't know how.
I was so aggravated resetting this back up to like my old laptop, but it was.
Oh yeah, if I get a new laptop,
Did you try to?
Like I was getting so mad.
Because mine was a PDF, like I just edited the PDF.
I'll have a question for you now. I'll have a question.
Next Thursday, because Tuesday, that's like next Thursday.
It's 5 pages and 3 references, right? References on what?
That's what I don't understand. I use the book as well, because she said it was nothing on that.
Only one website.
Yeah,
Really?
I think so, isn't that right? I know that's how it is for other things, but I don't know if I'm like one not here, or just like one in June. I don't know.
I'm not even
I don't
started,
even
so.
know saved.
So,
It just says like for your references, that's on the interview, and I have to follow the sheet.
because I just edited the PDF, and I'm wondering if that's why mine didn't submit or something. See, because you can see, like, I even make the little marks of like what I used, so I could remember.
How do you get your thing today? Yeah,
I didn't put it on Word, I just submitted it like this.
how'd you get it on that thing?
I just opened it up like this and I put add text.
Excuse me?
Well, yours is, y'all are apples, so it probably doesn't do that. But, I don't know.
All right, learning objectives in this chapter. We're going to identify the intricate anatomy of the wrists and hands. Understand the components of an evaluation of the wrist and hand. Differentiate the common diagnosis as seen in the wrist and the hand. What we're really going to focus on today is going to be discussing the therapeutic interventions used in treating common wrist and hand conditions, and then implementing the treatment. Treatment plans for clients with common hand and wrist conditions. As with every chapter, you should read it prior to us going over it, so we can focus on interventions. But there's a few things that we're going to go over before we start on the interventions part. There's different types of assessments that we're going to discuss. You also need to review the, let me go back to it. The hand anatomy. So let's look at the hand anatomy really quickly.
That was a good little video. I like how you broke it down.
Huh?
If you're a homeowner in West Virginia and you're still paying for electricity, then you could be missing out on free government assistance to go solar. Most people don't know this, but in 2005, the federal government passed the...
Hold on.
Few structures of the human anatomy are as unique as the hand. The hand needs to be mobile in order to position the fingers and thumb. The hand.
Oh, it's muted on here. It's going to be loud.
Few structures of the human anatomy are as unique as the hand. The hand needs to be mobile in order to position the fingers and thumb. The hand must have adequate strength to grip objects firmly, but must also be coordinated to perform fine motor tasks with precision. The important structures of the hand can be divided into several categories. These include bones, joints, ligaments, tendons, muscles, nerves, and blood vessels. Let's define some common anatomic terms as they relate to the hand. This will make it clearer as we talk about the structures of the hand later. The front or palm side of the hand is referred to as the palmar side. The back of the hand is called the dorsal side. The half of the hand from the middle finger to the thumb is called the radial side. The other half is called the ulnar side. There are 27 bones within the wrist and hand. The wrist itself contains 8 small bones called carpals. The carpals join with the 2 forearm bones, the radius and ulna, forming the wrist joint. Further into the palm, the carpals connect to the metacarpals. There are 5 metacarpals forming the palm of the hand. 1 metacarpal connects to each finger and thumb. Small bone shafts called phalanges line up to form each finger and thumb. The main knuckle joints are formed by the connections of the phalanges to the metacarpals. These joints are called the metacarpophalangeal joints, or MCP joints. The MCP joints work like a hinge when you bend and straighten your fingers and thumb. The 3 phalanges in each finger are separated by 2 joints, called interphalangeal joints, or IP joints. The one closest to the MCP joint is called the proximal IP joint, or the PIP joint. The joint near the end of the finger is called the distal IP joint, or DIP joint. The thumb only has 1 IP joint between the 2 thumb phalanges. The IP joints of the digits also work like hinges when you bend and straighten your fingers and thumb. The joints of the hand, fingers, and thumb are covered on the ends with articular cartilage. This white shiny material has a rubbery consistency. The function of articular cartilage is to absorb shock and provide an extremely smooth surface to facilitate motion. There's articular cartilage essentially everywhere that 2 bony surfaces move against one another or articulate.
The breakdown of that cartilage is what causes osteoarthritis. Okay?
Ligaments are tough bands of tissue that connect bones together. 2 important structures called collateral ligaments are found on either side of each finger and thumb joint. The function of the collateral ligaments is to prevent abnormal sideways bending of each joint. In the PIP joint, the middle joint between the main knuckle and the DIP joint, the strongest ligament is the volar plate. This ligament connects the proximal phalanx to the middle phalanx on the palmar side of the joint. The ligament tightens as the joint is straightened and keeps the PIP joint from bending back too far or hyperextending. Finger deformities can occur when the volar plate loosens from disease or injury. Many of the muscles that control the hand start at the elbow or forearm. They run down the forearm and cross the wrist and hand. Some control only the bending or straightening of the wrist. Others influence motion of the fingers or thumb. Many of these muscles help position and hold the wrist and hand while the thumb and fingers grip or perform fine motor actions. Most of the small muscles that work the thumb and little finger start on the carpal bones. The bulge of muscle at the base of the thumb in the palm is called the thenar eminence. The bulge of muscle at the base of the little finger is called the hypothenar eminence. 4 muscles make up the thenar eminence: the abductor pollicis brevis, flexor pollicis brevis, adductor pollicis, and opponens pollicis. Pollicis is the Latin term for thumb. Each of these muscles begins at the wrist, and each has a tendon that attaches to a different location on the base of the proximal phalanx of the thumb. Their names give a suggestion of what they do when they contract. The abductor pollicis brevis abducts or moves the thumb away from the midline of the hand. The flexor pollicis brevis flexes or bends the thumb. The adductor pollicis adducts or moves the thumb towards the midline of the hand. The opponent's pollicis moves the thumb into opposition. It pulls the thumb out from the palm and turns the pulp of the thumb to face the palm. This is the motion that allows you to place the tip of your thumb against the tip of your little finger. The muscles of the hypothenar eminence are arranged and function roughly the same in the little finger. The smallest muscles that originate in the wrist and hand are called the intrinsic muscles. The intrinsic muscles guide the fine motions of the fingers by getting the fingers positioned and holding them steady during hand activities. The tendons that allow each finger joint to straighten are called the extensor tendons. The extensor tendons of the fingers begin as muscles that arise from the backside of the forearm bones. These muscles travel towards the hand where they eventually connect to the extensor tendons before crossing over the back of the wrist joint. As they travel into the fingers, the extensor tendons become the extensor hood. The extensor hood flattens out to cover the top of the finger and sends out branches on each side that connect to the bones in the middle and end of the finger. The place where the extensor tendon attaches to the middle phalanx is called the central slip. When the extensor muscles contract, they tug on the extensor tendon and straighten the finger. Problems occur when the central slip is damaged, as can happen with a tear. The flexor tendons allow the fingers and thumb to flex or bend to grip objects in the palm of the hand. The strong flexor muscles begin in the forearm, and just before they enter the wrist, the flexor muscles form the flexor tendons. The flexor tendons travel through the carpal tunnel, through the palm, and two tendons each travel into the volar side of each finger. These two tendons, the flexor superficialis and flexor profundus, travel through a special tunnel formed by a series of specialized ligaments that form pulleys. The flexor superficialis connects to the base of the middle phalanx. The flexor profundus tendon connects to the base of the distal phalanx. The thumb is a bit different since it only has two phalanges. The flexor pollicis longus begins in the forearm, and its tendon connects to the base of the distal phalanx of the thumb. The flexor pollicis brevis muscle begins in the wrist, and its tendon connects to the base of the proximal phalanx of the thumb. All of the nerves that travel to the hand and fingers begin together at the shoulder. The radial nerve, the median nerve, and the ulnar nerve. These nerves carry signals from the brain to the muscles that move the arm, hand, fingers, and thumb. The nerves also carry signals back to the brain about sensations such as touch, pain, and temperature. The radial nerve runs along the thumb side edge of the forearm. It wraps around the end of the radius bone toward the back of the hand. It gives sensation to the back of the hand from the thumb to the third finger. It also supplies the back of the thumb and just beyond the main knuckle of the back surface of the ring and middle fingers. The median nerve travels through a tunnel within the wrist called the carpal tunnel. This nerve gives sensation to the thumb, index finger, long finger, and half of the ring finger. It also sends a nerve branch to control the thenar muscles of the thumb. The thenar muscles help move the thumb and let you touch the pad of your thumb to the tips of each finger on the same hand, a motion called opposition. The ulnar nerve travels through a separate tunnel called Guillon's canal. This tunnel is formed by two carpal bones, the pisiform and hamate, and the ligament that connects them. After passing through the canal, the ulnar nerve branches out to supply feeling to the little finger and half the ring finger. Branches of this nerve also supply the small muscles in the palm and the muscle that pulls the thumb toward the palm. Each finger has a pair of sensory nerves, one on each side, that runs to the tip of the finger. These nerves are called the digital nerves and supply sensation to the fingers. Traveling along with the nerves are the large vessels that supply the hand with blood. The largest artery is the radial artery that travels across the front of the wrist closest to the thumb. The radial artery is where the pulse is taken in the wrist. The ulnar artery runs next to the ulnar nerve through Guillaume's canal, which has been mentioned earlier. The ulnar and radial arteries arch together within the palm of the hand, supplying the front of the hand, fingers, and thumb. Other arteries travel across the back of the wrist to supply the back of the hand, fingers, and thumb. When our hands are free of problems, it's easy to take the complex anatomy of the hand for granted. The hand is formed by numerous structures. Each has an important role in the normal hand function. Injuries and conditions that change the way these structures work can greatly impact whether the hand functions normally.
Okay, so out of all that, you do need to know the joints in the hand. I'm not going to make you memorize the carpal bones.
Hi, I'm Dr. Brian Paris, and I have an important question for anyone.
All right, so I'm not going to make you memorize the carpal bones right now, but you do need to know where the thenar eminence is, where the radial eminence is. You need to know, I'm sorry, the ulnar eminence. You need to know metacarpals, carpals, what type of bones they are, the phalanges. You need to know the IP, the DIP, and the PIP, also the MCPs. And if there's anything else, I'll let you know. I can't really think.
That thenar eminence, that's all those muscles.
You need to know where it is. You don't need to know the actual muscle there. You do need to know that anything that creates extension, your extensor muscles and ligaments and things like that, are all on the back side of the hand, the dorsal side, okay? The flexion muscles, tendons, all that are on the palmar side, okay? So it's on the anterior side. That'll just make it a whole lot easier when you have to identify muscles and things like that. You need to know where the radial nerve, the median nerve, and the ulnar nerve are in relation to the hand. All this will help you with splinting. All right, so we're going to talk about some evaluations of the hand. We're not going to go over all of them because there's like 50. All right, so we're going to do the ones that are most common to our geographical region. And we're going to discuss what we look for during an evaluation of the hand. Now, most often, it'll be the OT that does the evaluation part, but we do the assessment. And the book is using evaluation and assessment simultaneously. So assessment means we assess how much edema a person has, or we do a specific assessment for like carpal tunnel syndrome. The evaluation is when everything is taken into consideration and a treatment plan is then developed. Okay, so we just do specific assessments that the OT